Thank you. I'm really glad to be here today to give you some information about our experience thus far. All right, that's the direction. Just first of all, a little bit about our health system. I do come from Northside Hospital. It's a 3-hospital health system at this time. And we have 3 locations. You'll see listed here just a picture of the 3 locations in Atlanta, in Forsyth County, and Cherokee County. And between those 3, we represent over 1,000 licensed beds. It's all not-for-profit hospitals. We have affiliations with outpatient centers and medical office buildings all throughout the North Atlanta metro area. We represent 2,900 physicians on staff, more than 15,000 employees, and we have 3 million patient encounters annually. All of our hospitals are full-service acute care facilities that offer particular expertise in maternity services, women's health, cancer care, surgery, and radiology. And with these type of specialties represented in this number of practices, you can understand we have multiple ultrasound probes. So to begin with, prior to the toolkit or even any information about this, we had our ultrasound probes on our minds. We were in the window for our Joint Commission survey in April of 2018. We had already had our 2 other hospitals surveyed successfully, and we really felt like we had those endocavitary probes covered. It was my responsibility to know where they were located, to know that we were compliant with how they were being processed, how they were being transported in both the clean modality as well as the soil modality, and how they were being stored. So I'd done some work, a lot of work on that. I will tell you, even though we thought we were ready, sort of at the 9th hour, where there was a surprise ultrasound probe that was found in one of our surgical locations, which I quickly was able to get us up to speed on, but that did give us a little question in our mind about what might else be there. But during the same time, when of course we're looking in all of our departments and we're trying to find any little holes in our processes, infection prevention and the surgery team started looking at the vascular probes, and they brought those to the forefront. And with that, they did a tri-campus probe inventory. And then they started determining, okay, which ones do we have? Which of the Dopplers can we use that are single-use, disposable? Can any of them be sterilized? How many of the heat-sensitive ones do we have? And then a light went off in their heads, and they said, hey, we need to involve Betty on this for high-level disinfection. So I was added to their group. So we called it our compliance team, just to be sure we were where we needed to be and to do a little additional work. So I started looking at how the probes that were within the surgical area, because mind you, I had been in on all of the endocavitary throughout the organizations, but not on these surface probes that might be finding their way into surgical procedures. I had as my document the SDMS Guidelines for Infection Prevention and Control in Sonography, Reprocessing Ultrasound Transducers, which was under public comment at the time. But it was a very good document that was based upon guidelines that were from the CDC and from AMI, et cetera, and the FDA. And they had actually some algorithms that were not bad at all and gave us some guidance. So once again, I started focusing in on the pre-cleaning, used this document also for algorithms. I also had some educational materials that I had gotten from Nanosonics. Excellent pieces. I've given you these 2 titles. High-level disinfection, why and when. It helps to educate those who are new to the process. And why high-level disinfection of surface probes is essential. So we put together our team, we met in April, and then a light went off in our heads, said, maybe we need to let the surgeon know, because we were going to be disposing of a lot of these probes that were actually Doppler type probes. And so we were going to be spending some more money, as well as the fact for these devices that were heat sensitive, that couldn't be sterilized, we knew we had high level disinfection needs. So we knew that would mean glean, okay, do these areas have any of the automated sonicated hydrogen peroxide probe disinfectors? Well, we knew we had one in radiology that was near the ground floor surgery area, and we knew we were going to have to take the surface probes that were being used in contact with blood or tissue, specifically the carotid cases, where that nice little surface hockey stick probe would just make its way underneath the skin into the tissue over the vessel to check the integrity before totally closing. So we did let the physician know that. He was quite supportive because we wanted him to know there would be a little delay, perhaps, from what he was accustomed to, which was formerly just a wipe down and stick on another sterile cover between cases. But he was going to have at least 7 minutes for the disinfection process after the cleaning had been done. So we also updated the vascular section folks to get the other surgeons on board. We knew we had educational needs that needed to take place and capital quotes for additional probes, because if you're tying up a probe, you don't want to tie up the next case. So that was on our minds. We rushed the team a little bit to be ready for our imminent survey, and so we kept track of our schedule for EVOR. We focused in on anticipated probe usage and targeted those carotid cases. So we had our visit, and we had no HLD findings, which we're very proud of. We were visited in every single location where we had high-level disinfection, but the only ones that were looked at were the endocavitary probes. And so we felt like we were ready, but when we really thought about it, as far as being ready totally 100%, we weren't. We were about 50% for vascular. We really hadn't hardwired everything. So we said, we just need to keep moving through other specialties. So after our survey in June, I suddenly became aware of Ruth Carrico's 2018 article, wonderful article, Ultrasound Probe Use and Reprocessing, Results from a National Survey Among U.S. Infection Preventionists. And it just opened up all sorts of understandings about what was going on, startling information, numbers of devices and the contamination rates, et cetera, and it was very alarming, but quite right up my alley for being able to help folks to know why they needed to do what I was recommending they do. I learned that this toolkit was coming, but before that, I, of course, got with other infection prevention colleagues and came up with this idea to have an official probe special project that I would co-lead with our infection prevention specialist on sterilization. So we felt like that was kind of a marriage made in heaven, so to speak. But we realized that the enormity of this project was going to be such. For the size of our health system, we knew we couldn't do it overnight, and we didn't want to try to do it overnight. We wanted it to get going and become hardwired. So we said, this is going to take years, not months. So we figured maybe a couple of years totally. So let's see what has happened. So once again, in June, I met with my proposed co-chair. We made plans to prioritize our specialties by criticality and size. We felt like vascular was critical enough in this identified usage that we would stay with them, and yet it was a smaller volume for our specialty. So we figured if we could have some successes in a smaller area, we could then move on to some larger specialties. We decided we would roll it out to each campus separately. I told you we were a 3-hospital health system, and we all are under one name. However, each one has a different personality and maintains that personality. And so rolling it out at one doesn't mean it's easy to do the same process. So we knew that we would do it each one separately, and we agreed, though, to keep everybody involved during all of our meetings where we were planning. We'd have the physical meeting at the targeted current location, but we'd have phone access for our other campus attendees. And we do a lot of phone meetings, but this way at least they would be aware so that it wasn't their campus we were working on, but they would be next, so they could do some things behind the scenes to get prepared for us to come. So we determined our appropriate stakeholders that we needed to include for our vascular team, and we started our meetings August the 1st. So now we're going to move into some of the components. So tool number 1, locate and profile. So what it actually does, and once again, you heard just previously how it is difficult to find the probes. What we decided to do was, in using this where there are strategies to find your probes and to assess the practice, we decided to say, okay, this is the specialty we're working on. So would you share with us your inventory? Well, light goes off in one's mind because it's like, well, we don't really have one. We just depend upon biomed. And once again, I mean, I have to repeat that feeling. You ask biomed and you get this list in micro print, and it's like, but they have no clue, and they have different names. They just know that they were purchased and that they do some sort of servicing of the machines. But if you ask the specialty area to go ahead and conduct their own inventory and say, I'll help you, and I have some resources that I can use to help with that, then they get ownership of it. And then they have a document then that they can keep forever and keep updating it. So that was the first one. Here is a screenshot of this. You'll see part A is where there are example strategies for ultrasound machine location listed here. And then part B would be the checklist that the user would use to see, okay, looking at the policy, are we doing it this way? Are we doing it that way, or do we have nothing to go by? And if you had answers in the shaded boxes, then you need an action plan. So that's really a very simple type of a tool. Tool number 2, I can't speak more highly of. It's the algorithm, and it offers a decision-making guidance on every little piece of the process. We are using it as our most valuable tool. It absolutely guides our project. Here you see an example of 3 specialties. These are all broken out by department, department-specific probe use, and reprocessing requirements. And so these are based on all of the guidance requirements. It's FDA, CDC, AMI, and APIC. And they also can be used as a printed reference guide in the department's procedure room. Our plans for this and practice so far are that we start and we use this document, and then at the conclusion of that specialty, we have them laminate them and then use them to post in their areas for future reference. Tool number 3 is the risk assessment. It offers a comprehensive risk assessment template. So how have we been using it? Well, rather than just calling it a separate risk assessment for this, we've used it a little less in a less structured, more informal basis. But what we do is we absolutely have set up and revised processes based upon it. One quick example would be in finding the appropriate ultrasound transport container. You know, I have many, many years experience with endoscopes, and of course the thing about high-level disinfection of endoscopes, you can submerge everything. In days past we couldn't, but in more current years you can. And so then when you think about the whole device is high-level disinfected. However, with your probes, you've got your high-level disinfected probe and handle portion, but then you've got a long cable and housing unit. They're low-level disinfected. Well, if you put them all in a cleanoscope type bin or a plastic container, you're going to have cross-contamination, whether it's post-HLD or whether it's when they are soiled and being transported. So we did some searching and found that there are some containers there that actually have a section so that you can put the high-level disinfected portion or soil portion on one side and the low-level disinfected portion on the other side. And they're lightweight and they're compact and fit nicely. So that was one of the examples, because we did look to see how much risk this would entail. And then once again, traceability. I can't say enough about traceability, but once again, that using the logbooks for the traceability so that I can walk into the department doing a tracer and I can ask, who is this used on? How is it prepared prior to its use, et cetera, in a quick visualization. So here's an example of the risk assessment, and this will walk you through an editable hazard table and a matrix to help prioritize your hazards in terms of risk at your facility. So you'll see you begin with your hazard type, what the hazard is, what is the potential harm, how likely will this happen, what is your harm severity, your risk, and then some examples. And if you score anything that is greater than low, then you need to, have a plan for that. So this is a great example of your risk assessment tool. The number 4 tool is development framework for the policies and procedures. Some years back, I know when I moved into my current position, wanted to make standardization, so I have a standardized high-level disinfection policy, and then separate policies on reprocessing flexible endoscopes, and then also another policy on handling of the endocavitary probes. So for one thing, I knew with this, need to do a little tweaking to that, because now we are actually high-level disinfecting some surface probes that are being used for other purposes. So we found some opportunities there to look at our existing policies, and we even found some opportunities to add some verbiage, as well as an additional policy to look at specific probe barriers and gel use. Here is an example, and what's great about it is it's a comprehensive development process for the policies. It draws on your federal guidelines, national standards, and peer-reviewed literature. It's ready to go for your facility. It's editable. You don't have to sit and write a policy, and why reinvent the wheel? So what we did is we set up our specialty priority using our toolkit number 2. And you will see here we started with vascular. We wanted to move then to a large area, and that's radiology and interventional radiology. Oncology, a little bit lower in number. Cardiology, kind of moderate. Anesthesiology, huge, very huge, and we haven't gotten to that one yet. Emergency, on the smaller side. OB/GYN, we've done a lot, and it's mostly endocavitary, but we know we've got some opportunity there. Beyond that application. Neurology, nephrology, those are 2 smaller ones. We added to the musculoskeletal orthopedics our melanoma and sarcoma clinic, and we really haven't totally thoroughly explored, but we wanted to be sure they were included, and this is the arena they fit into. Pulmonology and gastroenterology combined, and then finally we added dermatology. So like I say, algorithms guide the processes. Here you'll see 2 examples. What happens is you look at the use of the probe and you classify how they're going to be according to Spalding, whether it's a critical usage, whether it is a semi-critical, or whether it is a non-critical. And then once again with the algorithm, you look at what procedures are we doing with this particular probe or probes, and then how do we need to handle these? So it really guides the process in every form. So we started our meetings. We started with a purpose. And our 2 purposes, and this is for our whole project, is we wanted to make sure we were using the appropriate patient protection during our probe use. That includes whether it's single use versus the appropriate level of processing, probe covers. And then also we wanted to ensure practice standardization across the system. Decrease your errors, have it standardized. Sometimes we'll float staff between locations. You may see a radiology staff person at one location and then at another. And if they're working in ultrasound, they need to be doing the same thing. We needed to address these topics from the beginning. Education, why are we doing this? We had to help folks understand why we're doing it. What needs to change in order to do this? Competency, pre-cleaning, huge. I've watched some of our ultrasound technicians and technologists cleaning a probe, wipe it down, it's clean. Not so, I've done some testing on that. Automated probe disinfector, really simple to use, however, very important to have them clean and dry and to move through the process that way. And so these require not only education, but as you know, education and competency are two separate things. So we knew we needed to move through that with both levels. Ongoing monitoring, I talk about the logs and traceability, that's part of our quality monitoring. And then I conduct high-level disinfection rounds on all the areas where they have high-level disinfection. During the regular years, I do it every other month. And then that's in addition to what they are expected to do in their own department on that off month. And then I also, during our getting closer to some survey times, I do it every month. Additional topics, we wanted to make sure, okay, we're bringing you all of these things that you need to be doing now, so what resources are there? We have to look at staffing. Is that going to require an extra staff member that's going to have to take this device to another location to have it processed? Equipment, what is your current inventory? There it comes back again. How many of the disinfectors do you have on hand? And if you have to get some more, where are you going to put them? Transport trays, if you don't have any, how are you going to start your process if you are just going to walk the probe down the hall hanging onto it by hand? So in that process, you know, how many additional probes might you need to keep up your current practice? What about construction needs? We actually found in our endovascular area, we knew a workroom location for our device for processing, but they had a bunch of junk in there in addition that they said couldn't go away. So we actually had to build a little cubby so that they could move their paperwork out and we could move in to do our processing. Always address progress to date. Where have we come to at this point and where are we going on our next steps? Follow-up assignments. Always make follow-up assignments with names. Meeting logistics. How frequently shall we meet and where are we going to meet? So where are we now in our project? 9 months later, we've completed the vascular specialty at all 3 campuses. Now, I will have to say, in our defense, it really didn't take 9 full months. We had to take 2 months off from having meetings. Not that our processes weren't taking place, but we had a new electronic medical record system that was being implemented, and we were told there are to be no meetings that don't relate to the computer between October and November. So we had to do that. And then in December, we came into the holidays. So I'll have to say that maybe 6.5 to 7 months that it took us. But we're ready to go with the next specialty. When I was preparing the slide, we had already met with radiology as far as the designated stakeholder to begin with. An initial meeting went away from there because they didn't have a complete inventory. So that was going to take a bit of time. But since that has happened, and said, okay, I'll give you 2 weeks because we're going to meet again. So at the time it was in progress, it actually has been done, and we've had a 3rd meeting, and now we'll have a 4th one on Monday, where we actually are looking at the low-hanging fruit opportunities in the areas to get going. So what lessons have we learned so far? I am quite a proponent in learning from my mistakes or learning from other people's best practices or just learning from the process. So you need to involve the correct stakeholders. You may think you know who needs to be involved, but it may change along the way. And feelings can be hurt because a person will say, well, that's my specialty, why wasn't I called in? And I don't know all those other people, so I invited the folks I was told, so I can apologize nicely and then heavily involve those people. But try to get to the correct stakeholders. Use the task force structure. Don't say it's a committee. Say it's a task force because that has an end in sight. That feels a lot better than you're on a new committee. Frequent meetings we do every 2 weeks. I believe in every 2 weeks. Keep your minutes. I'm the minute taker at this point. I'm fine with that because I do it very detailed so that one can't say, well, I don't think we really talked about that. Oh, yeah, we did. Make assignments for follow-up, even if it's a simple task like having an outlet installed. And we had this. We had this automated device ready to put in the area, and it was, meetings we do every 2 weeks. I believe in every 2 weeks. Keep your minutes. I'm the minute taker at this point. I'm fine with that because I do it very detailed so that one can't say, well, I don't think we really talked about that. Oh, yeah, we did. Make assignments for follow-up, even if it's a simple task like having an outlet installed. And we had this automated device ready to put in the area, and it was, meetings we do every 2 weeks. I believe in every 2 weeks. Keep your minutes. I'm the minute taker at this point. I'm fine with that because I do it very detailed so that one can't say, well, I don't think for all my years involved in it would be something that would be that easy for folks to understand. Take your accomplishments forward to your future specialties. One example are clean covers. They're actually called clean bags. And where we got into this is we started in the endovascular OR, so of course at the end of the cases, everything in the room is wiped down, including the probes should be, the surface probes that are sitting there should be wiped down. So we started looking at, there was the question about, well, should we just put a probe cover from our automated devices over all of these surface probes? I don't like that idea because I may then say, well, looking at it, okay, this has been high-level disinfected. It's ready for me to use. So we went back to the drawing board, involved some of the team members that reached out to vendors, et cetera. Actually, we've now come out with a really nice clean bag that's very inexpensive, and it will cover all of the surface probes that are not already prepared for high-level disinfection for their patient protection. And we also, another accomplishment, we've added just 2 so far of the sonicated hydrogen peroxide probe disinfectors, making us with a system-wide of about 50, but we know we'll get more. Tailored the disinfection log form to the specialty because there's this cross-utilization. And if you looked at my log form, you know, we chose 7 days for hang time because we needed to standardize, since we used 7 days for our scope hang time, and we needed a time. Otherwise, you could have some departments that hadn't used that probe in 6 months. So to make it easy for everyone, we said choose a day of the week, and if you haven't used them, process them again. So we have a little checkoff box on our log to where we're not expecting a patient label to marry up with that label from the disinfector, but the checkoff just said this was just a 7-day reprocessing. So on this particular case, because we had some uses that were just for external, so I used it for a sterile application. I had to minimally high-level disinfect, but now it's all done, so I've actually disinfected it again, but I don't expect to be using it for quite some time except for as a surface probe. Then they could check off the external use only. Resource manuals, we found that to be very important, especially when you're adding these new devices. The instructions for use for the equipment as well as for the chemicals that are being used, the safety data sheets, and I know these are also available online for many departments, but I like them to be right there where they can turn to them. And I make sure that we have the most up-to-date one when I do my rounds. Policies and procedures, what policies are you following when you're doing all of this? They need to have those hard copies. I know we have them electronically, but I like them to be right there. Most of your technicians don't have time to go and pull it up on a computer. Ordering information for consumables. Never run out of these covers, never run out of the chemical, never run out of these indicators. Processing logs, we have it all in this one resource manual in the beginning and then their patient logs. And one of the questions I ask them every time I do tracers will be, do you have your IFUs? Do you have your SDS? And all they have to do is go to the book, but this helps them to know that. The most important accomplishment, I have to say, is infection prevention and device utilization. I have to say, I think back to when CDC initiative came out about if you don't see your caregiver washing his or her hands and you're a patient, you need to ask them, have you washed your hands, or I haven't seen you wash your hands. And I remember at first in my practice that we were all like, I can't believe we're asking them to do that. But I almost think about this for our devices. You know, if I'm a patient and I'm having an ultrasound probe being used on me, I want to know that my caregivers have thought about it enough to use the Spalding guidance for my procedure. So they are taking the utmost caution to protect me when I'm getting these diagnostics that I may or may not really want, but I must have for my care, but to keep me from contracting a possible infection. So I can just see our patients at all walks of life saying, thank you, thank you, thank you. And I thank you for your time. And once again, we'll entertain any questions you might have.